job. It is an opportunity to come to hear professionals in various realms of the business world come and share with you not only their business-specific expertise, but perhaps their leadership experience, their life lessons that they would like to pass along. And it's really, it's one of my favorite things here at Southern. So I hope you'll enjoy it this year as much as we enjoy facilitating it for you. I appreciate the fact that you're all here on time and seated. I passed out little cards for your row and your seat number. The reason we're doing this is I'm doing a seating chart for attendance for the rest of the semester because there's 67 students enrolled in this class. And it will facilitate much easier taking attendance each week rather than reading out 67 names every week, which sometimes takes a while. So we're going to make a seating chart. So where you're at tonight is where you'll be seated for the rest of the semester. If you didn't get one of these slips or your friends didn't give it to you, let me know. And you need one right here. And I'm going to collect those from you in just a moment. I know you've all gotten the syllabus. Most of you took the syllabus quiz with a couple of exceptions. Everyone made 100 on it. And that's a good thing. I appreciate you taking care of that item. Do you have any questions about the structure of the class that we didn't cover in the syllabus or in the emails that you got? Nope? Okay. I want to start with prayer, and then I'm going to introduce you to a couple of people. Father in heaven, I want to thank you for another opportunity to hear how you work in Dr. McKenzie's life. We look forward as he shares with us his experience and his knowledge. And Lord, may you write on our hearts what we need to know for our future. In Jesus' name, amen. I would like to first acknowledge Mr. Jan Hushing. Hushing. Raise your hand. He is the person who started the E.A. Anderson lecture series a long time ago.
1,000 years ago.
1,000 years ago. He also taught in the School of Business for 8 years, and we appreciate what he did to get this started.
Well, you need to thank E.A. Anderson.
Yes.
The money's what made it happen.
The money's what makes it happen. Money makes just about everything happen, doesn't it? That's right. I want to introduce, just in general, these are some of our community members, and I hope you'll enjoy their presence here each week. They tend to come very faithfully, and so we reserve both sides for community members when they come, as well as the back row to travel over to this side. So thank you for sitting here, and I'd like to introduce to you tonight Dr. Mark McKenzie. He's from Toronto, Ontario in Canada. He's a Southern alum. He earned his BA in biology and a BS in medical technology. He then earned his medical degree from the University of Toledo Medical College of Ohio, emphasizing in internal medicine. He's been married 25 years to his wife Carla, and they have 4 children, 3 of whom are enrolled in Southern and 1 who is at Collegeville Academy. And I think my favorite part of his bio was that he said, I love food, sports, music, Christmas, and Disney World. So please, welcome Dr. Mark McKenzie.
Thanks for having me this evening. There we go. As the title says, sticking to the mission. And of course, this could be anything, and I like to discuss it this way because each of us has an idea of what we want to do in life, and that changes as life goes by. I'm going to tell you a little bit more about myself, and intentionally want to express my background because it's apropos to what we're discussing this evening. Raised in Toronto, some of you have been there. I was looking around the room at the different city pictures, and this is my favorite city. Obviously, I'm going to say that for you. There are some things about Canada that are different than the United States, and primarily healthcare. We're going to talk about healthcare tonight intentionally to let you get a better grasp on what the American medical system is like and why that matters to you. Over the last 8+ years, you've heard about healthcare, government involvement in healthcare in this country. Prior to that, going back 50 years, some people who are a little older than most of you are will know about Medicare being established and what it's done for them over a lifetime. Regardless of what your political views are, everyone has an opinion on what should happen with healthcare. In Canada, I express this because when you grow up in a system like this and then move to another country and work in a different system, your viewpoint may change. Socialized medicine primarily, that means government has a heavy involvement with that. Canadians go to the doctor much more than Americans do. And depending on what side of the border you're on, you might have a view of the other that is not necessarily so. You're sick, you go to the doctor does what they can to help you, tests, pharmaceuticals, etc. Your taxes at a high percentage pay for your health care in that country as opposed to the United States. Our goals tonight, we're going to deal with what the American system looks like. We're going to talk about the business of being a doctor, and then we'll get back to why, and that's part of the mission. I like music, so I tend to throw quotes in there, and sometimes when I'm listening to a speech or a sermon or a lecture that someone says something, occasionally if I'm drifting, I will think of a song. In this case, Teddy Pendergrass, Harold Melvin, and the Blue Notes said, "The world won't get any better if you let it be." You have to do something to make a difference, and that's what that quote is about. Each one of us, no matter what your role is, has the ability to make a difference. All right, so you decide you want to go medical school. Are there any pre-med students in the? All right, welcome. The biggest thing you're going to be asked, first on your application to medical school, you'll have to write a personal statement. You'll also be asked the same question when you go to your first interview, why you want to be a doctor. By the way, of the three that I saw hands raised, anybody already know why they want to be a doctor? Why?
I really enjoy helping people, and I enjoy the human body. I love learning about it and how fascinating it is.
That's the most common answer. And there was a time when medical students or medical school applicants decided, well, I want to be different. I want to come up with something unique. But your interviewer wants to hear that. They want to know that you want to help somebody. That's the main reason they expect you're coming to medical school. Other reasons, of course, some people say it's interesting, and it is. The human body is interesting. Obviously, God made us, those who believe that way, and in such detail, and how it works together, that we will continue for eternity to study the human body. There's so much we don't know as physicians, and so many things that are learned every day. And the way you learn them is different for everyone, but the body is interesting. Mom, Dad, my parents were not physicians, they were actually teachers. I had no one in my family who was a physician, I'm the first one. But for some of us, that's our motivation to go to medical school. You have a relative who's done it, you want to emulate them, and so you do that as a goal. Leadership. In some communities, doctors are looked at as leaders. Going back several hundred years, that was automatic. Nowadays, not so much. But in fact, by what you do, because people entrust you with their care, you are somehow guiding and leading. Financial stability, that was another common answer, though many people try to be reserved when they're talking about that. You can make a good living. And it doesn't matter if you're in Canada, Japan, Europe, or in the United States of America, physicians do make a good living. All about management, though, and that's where sometimes there's an issue. And then, of course, last but not least, I've heard this answer on applications. What else was I going to do? Sir William Osler, a Canadian physician, trained at McGill University. He was actually one of the, who we would consider modern medical fathers of what we do. Johns Hopkins University is where he really made his big name in leading the medical department there. Two of his quotes are favorites of mine. Physicians need a clear head and a kind heart. That kind heart sometimes gets in the way. When I'm busy, I'm hurting, some other stress is going on in my life. That's where I still need to focus, so that when you come to me, I'm willing to listen and give you my best. Second quote is, medicine is learned at the bedside, not in the classroom. You can study everything, but if you don't interact with patients well, it really doesn't matter. If you you go to the doctor and they're not listening to you, would you likely go back? Most people would choose something else. Good listener is the most important thing, and so much of what you learn is from someone giving you history, and that's where that goes. So let's talk about the United States of America, healthcare spending. Does anybody have an idea as to how much or what percentage of a gross domestic product or GDP is spent on healthcare in this country? Top line is the United States of America. By the way, these are on e-class, I understand, so you'll have access to the slides. I do have some handouts for those who do not have access to e-class in case you want to look at the next 5 slides. They're pretty busy, and usually when you're presenting, you shouldn't give busy slides like this, but I think you need the data so you'll understand what we're talking about. United States of America, top line. 16 to 17% of our gross domestic product is on healthcare. These are all the other countries. This study actually includes 34 countries who are considered high-income countries. The top 13 are listed here, and of course there's some who have high income who did not cooperate in the study, but of those who cooperated and provided data and provided on a regular basis for the purpose of improving healthcare in their countries, we are number 1. And what's interesting is we'll find, and you'll see a little bit later, that we've actually slowed the growth of that expense, but we're still a whole lot farther ahead than anyone else when it comes to spending on healthcare. Not a recent phenomenon. You look back here in the 80s, we were top of the line as well, and that's continued to grow. Many reasons for that, and I'll explore that with you tonight. Highlight the United States down here, $9,000 total healthcare spending per capita. Next country with high numbers would be Switzerland and Norway, 6,000. Most everyone else is about half of what we spend, or less. Real average annual growth rate slowed down 10 plus years ago, 2.4%. Most recently, last 4 years of this study, 2009 to 13, slowed down to 1.5%. The way the money comes, public money, your out-of-pocket expenses, and there's some other things that we spend on, and that does not include, that includes things that you may do just because you want to when it comes to healthcare spending, but a lot of that is private money. You may work for an employer who matches some of the money you spend. You may have some other setup where you have additional funds outside of insurance or outside directly out of your pocket that you spend on healthcare. I think that's impressive that we're that high. MRI machines. I'm going to tell you a little story. I grew up in Richmond Hill, Ontario, which is it's a suburb of Toronto. Okay, that part of Toronto, 180,000 people. When I was growing up, we had 1 CAT scan machine, 1 MRI machine. My first job out of residency was in Bradley County, just north of here, and we actually had our own CAT scan machine in the office. I helped to get that in there. That was one of the things I thought was necessary because we were ordering a lot of tests at the hospital and losing revenue. So you actually change the way you think about medicine and medical equipment. If you go to Gun Barrel Road, you'll find at least 5 or 6 MRIs. You'll find MRIs, CAT scan machines. The hospitals, private groups, individual standalone centers, they'll have their own equipment. Unheard of in some countries, but Japan and the United States actually have the most when it comes to equipment. And if we have lots of equipment, you tell me you have a headache, come to my office, and I'm telling you, well, your history doesn't match that I need to look for a brain tumor, but you say, but doctor, I think I have a tumor. But doctor, I think you have a tumor. Guess what's going to happen? You're going to get a CAT scan. That's the United States of America. Why do you think that happens, by the way? Money is one. There's another reason, too, related to that. Why would I order that exam that you're...
Mitigate litigation.
Exactly, litigation. I don't want you to sue me when you might have that 1% chance of having a tumor, so I'm going to order the test, especially because I know I can call somebody and you'll get that the next day. Whereas in Canada, it might be several weeks before you get that. The American media, by the way, presents that as a problem. you can't get tests quickly. Mother needed a screening colonoscopy. Her doctor ordered it. It took 9 months for her to get that done. She was fine. Of course, I'm an American doctor. My younger sister also is, and we're jumping up and down and thinking, okay, come on, I can do this tomorrow. Why don't you come down here and I'll get one of my colleagues to do it? No, she said it's okay. I don't have any symptoms. I'm fine. And he tells me it's okay. She was fine, but still, we have a different expectation in this country than some others do. I talked about CAT scan machines, but you'll notice one of the things that's interesting is looking. I was trained in Ohio, Toledo. So the way you were trained fits with what we call standard of care, evidence-based medicine. When you start practicing or go through residency learning to practice, you start defending yourself. And that's what we were getting at earlier. So some of the habits have to do with what's available to you, what your personal experience is. If you have one mistake as a physician, you're likely to overdo to make sure you don't mess up the next time. And sometimes it includes ordering tests. So in the Netherlands, for example, and I can't explain it, the way they order tests, it seems that they do, where's that? Yeah. They do more testing, PET scan machines. By the way, anyone know what a PET scan machine is? Most time, the likely time you come across that is if you develop a tumor of some kind. I find that on a CAT scan. I'm going to look to determine if there's any other activity similar to that anywhere in your body. And that machine can tell us pretty quickly if there's inflammation related to that mass or tumor somewhere in your body, and then we'll go after that. So in the Netherlands, they seem to order a lot more of those tests than we would in this country. But on the other hand, lots of MRIs, lots of CAT scans in the United States. This slide talks about a combination. And the reason this is on here is to try to determine the habits of various countries. In the United States, we don't spend a lot on social care. Right now. We're the lowest when it comes to social care, and those are extra things that you might provide for your community. Depending on your political bent, some people consider that too close to socialism, so we don't like to give away entitlements, blah, 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 whatever you want to call them. Those are monies that are spent that come from the collective group, government, us, me and you, tax dollars out of our pockets to spend on people around you. But as I said, we spend between 16 and 17% of our GDP on healthcare in general. Why this is important is because of the next slide. Many people would assume we have the best technology, and we do. We have the easiest access, I think we do. As far as decision making, I can get things done quicker. So you would assume Americans should live longer. We do not. I say we because I'm American now. It's been about 10 years now since I became a citizen. Married my wife, she's from Indiana. This is where I've lived most of my life now. That's our life expectancy at birth in the United States. It's 78.8%. All the other 13 countries are above 80%. Why?
Diet.
Lifestyle, that's right. One of the common things is prevention medicine. We know it, we do it, but there are other factors too to consider. There's part of the study was trying to evaluate gun violence, and again, I won't spend much time on that because when you can't compare apples and apples, it's difficult. But a lot of these countries have different laws. Their freedoms might seem less than ours, but if you just talk about healthcare, taking out all the other factors, diet, exercise, prevention medicine, which is what we're supposed to preach, all of us believe in, they seem to do a better job except for one area, and that's tobacco. We've done pretty well educating ourselves in the last 50 years. Back in the early 60s, there were doctors who were still promoting nicotine or smoking as a good way to help your circulation, to relax your nerve, and in fact, to breathe better. One of my professors in medical school, my first year, it was fun for us to look out of the window during the winter time and see him out there taking doesn't make sense. But in the United States, we've learned, Surgeon General, early 60s said, no, enough's enough. We shouldn't do that. And we have a small percentage of the community, of the population that smokes still. It's about 20%, 19 is 19 point something. But as far as those who are the younger ones going, 13.7% these countries, you see there are many more of them that are ahead of us when it comes to that problem. But back to life expectancy. I was surprised when I saw that, but this has been something that's been going on for a while. The assumption is that we've got the best, we should be the best. Not so much there. The other thing that's interesting is the infant mortality per 1,000 live births. We shouldn't be that high. So there's something about the way we manage our healthcare. We have access to a lot of things. We spend the most, but we don't spend enough time on prevention. And that's one of the reasons American medicine is so expensive. One of the reasons it actually is going to be a problem that has to be dealt with no matter what your political views or background, is that number on the first of the 5 charts I showed you is increasing. So somehow, some way, somewhere down the road, somebody or a group or our leadership is going to have to address the problem, regardless of what you believe about the Affordable Care Act or other options like that. Medicare has been around for 50 years and it's worked. Obviously, some things need to happen so it doesn't run out of money, but it's worked for many of our people. And by doing internal medicine, by the way, I see a lot of Medicare patients, and these are people who are older than 65 or have a disability or have other issues that qualify for that service. Any questions so far about those? We'll get back to some more questions at the end. Yes, sir.
Can you explain real quick what social medicine is? I didn't really understand.
Socialized medicine is a kind of a catch-all term for countries that spend tax dollars for the collective on that. So in this country, you have pieces of socialized medicine, Medicare being one, Medicaid being another. But in other countries, it is the standard for all citizens or legal immigrants of the country that they have access to health care. If you came home sick, your mother wouldn't have to think, well, does my insurance cover this or not? You just go to the doctor and that's already something that's out of your tax dollars. Any others? Okay. So how does it work? This is the United States of America. You go to the doctor, hospital, or pharmacy, somebody has to pay, right? You get to choose in most cases. However, there are some who are part of a plan, and if that doctor, hospital, or pharmacy takes my insurance, I go there. If they don't, I go to another one. So there is some choice in most cases, and in other cases there's not, depending on what network you're part of. And these are terms you may understand based on the insurance that you or your family has. Insurance, health insurance, like any other type of insurance, pays for when there's a need. There's government insurance, 2 I've mentioned already, and then of course commercial. And then there's other plans where you, the individual, pay for your business. Medicare is a government-run program for age 65 and older. You're eligible at that time. Also eligible if you have a disability and you happen to be younger than 65. And then one specific disease consideration or illness consideration is renal disease. If you're on dialysis, you would qualify for Medicare because we consider that as a significant disability for the rest of your life. Medicaid is also a government-run program, but it's actually administered by the states. Each state does it a little different, and each state actually has different eligibility requirements. Part of what the ACA was trying to do, or Affordable Care Act was trying to do, was to encourage states to expand that. For many reasons, most states did not, but again, these are individual state-run programs that helps to pay for the expense of health care. And most of the eligibility has to do with income and your ability to earn. Then commercial insurance is the bigger piece. These are companies you may have heard of. Aetna is a common one, Blue Cross Blue Shield in Tennessee is a common one, Cigna, Humana, etc. So I choose to be a doctor. I go to medical school. I get my degree, I go through a residency of my choosing, and then I'm about ready to go out into practice, and I gotta figure out what exactly do I wanna do to practice. Private independent practice is what I do. I own my own clinic. I started my own clinic. I employ people at my clinic. We take care of patients together as a group. I'm the only physician. I actually have a full-time nurse practitioner and a part-time nurse practitioner. I've had various configurations of that. In fact, at one time I had 2 offices and multiple nurse practitioners, currently 1, and that's about all I can handle. The other option as a physician is you can go to work for a large group or a hospital. In fact, I should have put in there that insurance companies now are employing doctors directly to actually see patients under their umbrella. You can go into a teaching position. One of the things I considered was staying at my medical school and going back into as teaching faculty. Lots of reasons to consider that, others which don't fit what you're after. You can be an advisor or a medical director. 2 of my most recent years I spent as a medical director for Cigna HealthSpring. My responsibility was all of East Tennessee. When I was doing that, I only got to see patients in my office 1 day a month. The rest of the time, I was traveling around the state talking to doctors and other providers about population medicine and quality health, trying to get them to do the screenings that were necessary to help the population do better. And then, of course, there are missionary options, one of which you may have heard in the news about Doctors Without Borders. Some of us actually do this later after we practice for a while, then we decide to do some missionary work. Some of it's compensated, some of it's not. So you have a lot of options as far as a physician goes of ways to contribute. The old way of private independent practice is not as common. In fact, less than 10% of the primary care doctors in this county, Hamilton County, own their own practice. Most everyone works for a large group or is working for a hospital of some sort. 100 years ago, a doctor came to your house. 40 years ago, 50 years ago, you met the doctor in the ER when you had a problem, your primary doctor. 20 years ago, your primary doctor would round on you in the hospital. Currently, most of us don't go to the hospital. I stopped going to the hospital in 2006, and that was a trend that was going across the country. Because of all the responsibilities you have and some of the liabilities that come with that, most doctors have to make a choice. Either I'm going to be a full-time hospital doctor or full-time outpatient practice doctor. So what's the business about? Things I have to spend money on, stuff. I have staff, and that's probably the biggest expense for any private practice. In order to do the work you need to do, you need to be able to employ staff that are qualified to do that work. That's your biggest expense, and the taxes that come with that as well. You also have to have supplies. You've got to have paper clips, you've got to have tables, you've got to have paper, you've got to have supplies that are used for the work of running your business, as any business would. Then you also have to cover yourself. Should I have an accident or should there be a problem? Malpractice insurance is one of those. Building, renters, owner's insurance, depending on what your status is. Malpractice insurance is actually one of the reasons many doctors change or choose a career. Probably the most expensive of all of us are the OB-GYNs. Doctors who deal with obstetrics and gynecology have the most expensive. Primary care doctors have the least expensive. And that makes a difference for some as to whether they will go into that. How do you make revenue in order to deal with your expenses and hopefully turn a profit? Things that we've mentioned already. Fee for service. I take care of your sinus infection, you and or your insurance pays me for that. You can have straight insurance where that is the only way you make the revenue off that same visit. You may have heard of concierge medicine recently and cash pay. In this county, we have 3 doctors who are doing this, 3 primary care doctors, to where you sign a subscription agreement with them for the year. And I'll use an example. You pay them $1,000 and they take care of all your health care outside of the hospital for the year. In bigger cities, you see a lot more of that coming. There are companies that actually are promoting that to try to encourage us to come up with a model so that we're not in the insurance game. But in Hamilton County so far, I've identified 3 that are doing this. Cash, of course, you may have an account yourself as an individual that you set aside for medical care only. You don't have an insurance contract. You don't have any other third party who's paying for you, but you have a savings account or some sort of account that you use to pay for your health care. And then some of the new payment models for revenue for the practice we'll discuss in a bit, but that's what we do. Money going out, money coming in. 2016, biggest challenges that physicians are facing. Medical economics did this survey. Preparing for new payment systems, so let's spend a little time on that. The new way of looking at this, and one of the ideas that I think is a good idea, but may be difficult to implement, is how do we pay doctors? If you're paying fee for service, sometimes the incentive is to do more tests so that I will get more. If I own an imaging center, I want you to come and get more tests, doing good work, giving you the information, but you'll get more. If I own a hospital, I want you to come and have more procedures. Hospitals don't make money from people coming in with pneumonia unless there's a procedure attached to them. They make their money from big procedures such as surgeries, or they make their money from cardiac procedures. So one of the ideas that's come up is developing what we call medical homes or accountable care organizations. Those two are basically the same idea with a little bit of difference. But the idea is that I, a primary care doctor, internal medicine, taking care of adults, will be in a partnership with other specialists and a hospital, maybe a pharmacy and a nursing home. And together we're going to share data and try to take care of the whole patient with incentive from whoever's paying us, the government in the bigger cases, that if we spend less of their money, we will share in some of that bonus or potential savings. Whatever is left over that's assigned, we would share in that bonus. And so the incentive is to spend less, yet provide quality care. We're also evaluated, and the idea is this data will be available to everybody, so you can look up and say, what kind of rating does this doctor have? What kind of rating does the hospital have? And you choose where you go. Other possibility is you'll be assigned to one of these medical homes, and all of your care will be done. And another word will be a network. But the idea is in that network, in that medical home, in that clinic, in that physician, hospital, pharmacy, etc. arrangement, we will be able to manage your care for a whole lot less than traditionally done. Americans like to be free to choose. So if you have a friend who had a procedure and they tell you about that doctor or hospital or place they went for that procedure, you're more likely to want to go to that place. But say you go, not satisfied, you'd like to go somewhere else. You individually, at this present time, still for the most part have the ability to go from place to place to place in order to get the care you need. Very easy to get on Google, WebMD, whatever you use for your health care, and decide, I want this, so I'm going to ask my doctor to order this. I had an experience this afternoon, which was interesting. I had a patient call in and said they wanted 3 things. She had a rash. She wanted a topical treatment for the rash. She wanted actually 2 topical treatments for the rash, and she already had a diagnosis listed that it was, and because she had been to our office and we treated her and things improved and then they got bad again. And there was a 3rd thing she needed. I don't even remember what that is right now. But what made me smile about it was because, of course, I was thinking about my presentation to you, and I got on the phone and called her after I was done with patients and said, so what's the story? Well, she had a friend who had a rash that looked like her, and the diagnosis was psoriatic arthritis, and and she thought that was hers too. And the three things that the friend was doing, she wanted us to do for them. Now, mind you, when she came into the office, we didn't have the whole history. And so I started to ask her questions, and it turned out she'd started a new medicine early in the month of December. And for the last 5-6 weeks, she's had this diffuse rash all over her body. So what could have happened? She was choosing, as a consumer, she'd done her research, and based on her evaluation, this is what she wanted, and she felt like that would make a difference because it did for her friend. And I, as a physician, could easily have said, okay, because they weren't benign medicines, nothing too bad. I could have said, okay, you want it, you got it. But by talking to her and getting that history, we were able to determine that, oh, you did start a new medicine from another provider. Maybe you stop that, since the timing fits. So my expectation is in a week or so, things will be a little better. If not, then we'll investigate more. But my point is, when you are part of a organization that evaluates the quality of care you provide, those are some of the things that will come up. Are you just ordering? Are you just spending? Or are you spending a little more time to try to get to the bottom of it? Independence versus employment, doctors have to consider that more and more this year. And in fact, in this survey, I wasn't surprised that was so high. Part of it is because some of us are not comfortable with the idea of being part of any new payment systems. And sometimes it's easier to say, okay, for example, hospital A, I'll work for you, take care of patients in the office, and I won't have to worry about all that other stuff of managing a business. Major healthcare payers, four of the big companies last year decided they're getting together, two and two, Aetna and Humana, and then Cigna and Anthem. Yeah, Anthem. Yeah, Cigna HealthSpring, and that was actually a few years ago, but Anthem is buying Cigna HealthSpring. If the government approves the two sales, we expect those to go through sometime by second or third quarter this year actually. For us as physicians, if you own your own business, you fear that a little more because it means you have less leverage. You don't have, I can't say to Humana, well, you know what, I'm gonna go contract with Aetna because you don't get a good rate. I actually am stuck because they're now one company. I can't say to Cigna, I'm going to Anthem because they're trying to become one company. So the less of those together, then it takes away your ability to negotiate an appropriate contract. The rest of those I won't bore you with, but those are other things that are bothering doctors as we consider 2016 and what happens next. Go down to the presidential election, of course, when you listen to debates and speeches and statements, there are many who have a plan to change things. Not sure what the better options will be, but you have to think, okay, what does that mean to me in the business? What does that mean to me as an individual? Whether I'll be paying less taxes or more taxes, there's consideration there. Thurgood Marshall said, when we intend to do good, we do. When we intend to do harm, it happens. What each of us must come to realize is that our intent always comes through. Sticking to the mission. The reason I do what I do is because of service. There are lots of things that will allow you to make a good living. There are a lot of ways you can do it, which may be a little unethical. I think in the end, you have to consider why you did what you did. I actually thought I was going to have a chain of labs. When I was here at Southern, my first plan was to open up a chain of labs. Back in the 80s, the government changed the rules. And so hospitals could now serve as physician offices and provide laboratory services for them. So one of my degrees took away, the goal I had with that was taken away. All I could think of was being employed. So a lot of the smaller lab companies ended up consolidating and were bought by bigger companies. My idea of having a chain of labs is I would service however many physician offices we could do business with, but that obviously, when you're competing with a hospital who can afford more equipment and do things at a faster pace and has more staff, it doesn't work so well. I try tried selling life insurance when I got disillusioned with that idea. That didn't work. Tried that for most of a year, quit that pretty early, and then I said, okay, I'll go to medical school. Didn't want to be a doctor when I grew up. Some people have that dream. When I was here at Southern, that was never did I consider I'd be doing that. A lot of friends who did. In fact, what's funny is when you're a science major of any kind, biology or medical technology, you take a lot of the same classes. And so I had the background, but didn't have the desire. I developed the desire working in stat lab in Florida Hospital in Orlando, turning out thousands and thousands of tests a week, results that I would report to doctors and unit clerks and nurses, and just felt like that wasn't the place for me. However, I'm thankful that I got the opportunity to do what I do, and yes, when I went to medical school and had my interview, I told them I wanted to help people. I did. And I still want to help people, and I try to as well. I think independence allows you to do that. You can do the same whether you're employed or whether you're in another part of the medical business. But it's important to remember why you're doing what you're doing. And no matter your employment situation or your ownership situation, do your best to stick to that mission, which in my case, and hopefully in yours, and whatever you do, will be service. Any questions? Oh, by the way, the 28 days till the pitchers and catchers report. I'm a big Blue Jays fan. Baseball starts in a month, so that means it's getting there. Questions? Yes, sir.
You mentioned that there's a large shift away from the private practice model of operating for physicians. How much of that shift has been caused by the payers squeezing margins versus voluntary shift of operating?
I think the payer squeezing margins is the biggest. On a monthly basis, and in fact, more frequently than I want to admit, when you look at numbers and determine what you're getting from those payers and the things that they can deny. For example, because of my laboratory background, when I started my office, I had my own lab in the office. I had to suspend that after 2 years. I don't think we made it to year 3, because one of the major payers told me they weren't going to pay me at the same rate that they would pay LabCorp or Quest. LabCorp and Quest were the 2 biggest in our area, as far, and they're probably nationally now laboratories. And so, even though our contract allowed me to do testing in the office, because they were squeezing me, and I'm by myself, I just say, okay, I surrender. Thank you. Yes, sir.
You said there's a lot of shifting in how we do business in the medical world. What has been your hardest shift in which you practice medicine? How'd you deal with that shift?
Biggest thing, really, not so much in how I practice, but consideration. For example, if you have a medicine that I prescribe, I used to be able to just prescribe the medicine. Now I have to think of what your particular insurance's formulary is. So I'm still going to treat you, but I may send you to the pharmacy to pick up something and get a call back from you or the pharmacist that says it's not covered. Well, wait a second, is that my problem or is it your contract with your insurance? It's both of our problems, because my goal is to get you help, but it's very frustrating for me, frustrating for you, because you're standing there at the pharmacy. So now I have to think, okay, what is this going to cost? On my desktop, I have the Walmart $4 list of what they cover and the $10 list of what they cover. Use that as a guide because most everyone tries to match that. And so I will look at that and say sometimes, you know, this generic medicine I can get you cheaper price. It may not be the best option for me that I want, but you can afford it. The other thing that's interesting about that, we have drug reps. Some of you may end up in that field that come in the office. Most doctors don't like drug reps. Just that simple. But we need you. We interact with you. You provide us with new medications. Unfortunately, most drug reps want to educate the physician. And I don't have time between my patients who are waiting in the room and or the lobby to listen to your spiel about the Cytochrome P450 system. And what I just said is a system in the liver of breaking down of medications, which I don't care about anymore. Learned it in organic and biochemistry, learned it in medical school. I don't think about it now because it's not that important to me. It's important in the medicine, the way it's developed, the way it's used. But for that drug rep to tell me about it now doesn't mean much to me. Point is, my closet is full of new drugs that I might be able to give you a sample, but you'll never refill it because your insurance formula says that it's too new, we're not supporting that. And you're not gonna pay $200 and $300 out of your pocket for it. That's a shame. Yes, sir.
So the UK has relatively socialized medicine. They spend way less money on medicine than we do, and they have better better statistics health-wise. In general, they're healthier than we are. So the way I see it, the reason is that they spend such a percent of their medical spending on preventative care because there's more money to be made off of sick people than keeping people well. So do you think that the capitalist system of medicine has contributed to our high mortality rates and low life expectancy?
Yes. Absolutely. And that's part of what I was trying to say. I think we're going to need to change the way we look at medicine. There's a big debate that's been going on for a lot of years and continues to do so. There is one party that is in support of more government involvement in medicine and another party that's not. You'll hear candidates saying they're going to tear up whatever was done in the last 8 years, and another candidate says he's going to make it broader. And this is part of my bias because of my background, which is why I threw this in here, is I think medicine needs to be considered something other than. It's not a normal right. It's not normal business. I had a patient come back to my office saying that he was short on money, which he had just paid for his medical service the day before, $50. That was his copay. He paid us cash. That's been deposited in the bank, but he came back the next day to ask for that money back because he needed to buy something else that was important to him. Of course, we didn't have that to give to him, and I did not, but my first thought was if you went to the store and bought groceries, you would not then return to the store and ask for your money back. You would say, okay, I need to do something different. Medicine's not the same business as a variety store, as a grocery store. It's not like buying furniture or buying a car. I think we as Americans at some point in the future, maybe not now, but at some point, we've got to change the way we look at medicine so that we can take the best, which we have the best here. We have the best. We have the stuff. And do better than where our counterparts of the high-income nations around the world are. Yes, ma'am.
Do you think that there could be a solution between the insurance companies and hospitals and doctors included in like how they work with each other? Because, for example, like you were saying, they give you certain rates so you can decide to go with someone else. But in the end, I mean, right now you can still decide to go with someone else. But in the end, it's kind of like the consumer is the one who's being hurt because they can't go to you who they have a relationship with and they have to, So do you think there could be any kind of solution on that?
I actually don't think there can be, because our incentives are different. There are some things we can work together on, and part of this goes to my experience as a medical director. In the committee meetings, when we looked at medicines for the new year that they were going to allow on the formulary for this company, it was all about money. The advisors, my partners who were medical directors and I, would tell them what we thought was good about the medicine. The business people would say, well, this is what we can afford, this is what it will cost us. We look at statistics to see how much was being used in the prior year, what our competitors were doing, and then we tier that medicine to allow you to get it easier or not. The incentive of the company, because we are in a capitalist system, was to make money. Because they are also evaluated by the bigger payer, which is Medicare, or they want Medicare money to do what they do, the standard of getting quality care they have to live up to. So they have somebody they have to answer to, but the biggest people they answer to are the shareholders. And so I think the incentive as you, as a patient, as me as a physician, are different than the insurance company. And the government's incentive is even more different. And that's why I say it's difficult. More likely, we're not gonna get to the point where we all agree. Because if I run a company, I want the most profit when it comes to that. I, as a individual physician or local group, or if I'm part of a medical home and we're partnering together, independent practice organization, we're partnering together to do some things. Our incentive is gonna be different than the people we are trying to get paid by so that we can manage the patients. So it's tough. I think it's a culture change. I think it's an American shift, and shifts can happen because we shifted our views on smoking. When I was a kid, I'd ride in the car without a seatbelt. That's the way it was back in those days. Some of you wouldn't even know what that is now, but that's how we've changed. And so I think in medicine we can also change something. Other questions? Yes, ma'am.
With the increase in the number of, I will say, medical extenders, PAs, nurse practitioners in your practice, how has this affected you personally as a physician? And, you know, oftentimes we hear that this is a way of providing quality care for less money, again, driven by the finances. How does it affect your bottom line business-wise?
So, two answers. One is physician assistants and nurse practitioners are helpful in providing additional care needs by patients. It allows you to see more people and address some of the smaller needs that don't require the level of education that the physician has. Second answer is there is that risk of competition, which can affect the business, and also because the training is different, the viewpoint of the physician may oppose that mid-level provider, nurse practitioner, or PA. So I think it can help in places, especially where there is not enough physicians available. And I think it can hurt if there is someone overstepping their bounds in their treatment decisions. Our school here has a strong nursing program. They put out nurse practitioners, and now, most recently, they've started providing doctors of nurse practitioner. It's a DNP degree. The biggest objection you'll hear from physicians is that DNP gives the nurse practitioner the name of doctor without the clinical years of training that the physician has to go through. There's more to come on that. I think it's good to have more mid-level providers available because primary care physicians are shortage across this country. But I am concerned as to the skill level and making sure you get the best care in who you go see. I'm very comfortable working with NPs. Obviously, as I told you, I have several in my experience, and 2 in my practice right now, and I've had more at one time. I think it's a collaborative thing, which is good. Yes, sir.
I noticed you mentioned telemedicine as one of the challenges for 2016. I know some insurance companies are starting to use that as kind of like a screening process. A similar question to what she's asking, how do you see that affecting you as a doctor? And do you see that as a way to reduce cost and work with insurance companies better?
Personally, I don't see it affecting me. I think that's a good way to triage, and I do think it will reduce costs. I'd rather somebody get on the phone, speak to a provider in telemedicine, than go to the emergency room for a sinus infection. But if I can't examine, the way I was trained, I need to listen to you, I need to touch you, I need to make some decisions. If I'm writing antibiotics without physically seeing you, examining you, it's difficult for me to accept that as an appropriate way of treatment. And so to me, that's another change in this country, which I see as a potential problem. Good from a screening, hopefully we'll keep people out of the ER. Bad from a treatment. One of my patients actually told me recently that they got antibiotic prescribed by somebody that their company had seen them through telemedicine. I'm uncomfortable with it. But she didn't have to leave the house. So there are pros and cons to it, but I'm concerned about, are we gonna get more antibiotics out there that affect the population, and then we have less to choose from over time? That's my concern. Yes, sir.
You said there's been a lot of changes with nurse practitioners coming in, and of course with the Affordable Care Act. What advice do you give future doctors that are about ready to go to medical school and get hundreds of thousands of dollars in debt?
It's a rewarding career. And that's why I highlight the mission. Do what you do because you love to do it. Be a doctor because you really want to be a doctor. Don't let any of this scare you. Just come out of medical school knowing that when you choose a residency, the way you learned, or historically the way we practice, will be different than the way you're practicing. I've only been out of school 15 years. Yeah, 15 years. And a lot's changed in that time. I told you that in 2006, I stopped going to the hospital. When I first came here to Bradley County, I was going to 2 hospitals, rounding in the morning, seeing patients all day, rounding in the evening to finish up. We were laughing about it the other day, my wife and I, because sometimes, and there was no easy way, I live in Ooltewah, drive to Bradley County, it's 20 miles to the hospital. Sometimes on my way back from the hospital, as I get off the exit, I'm being paged to come back and see another patient. The lifestyle has changed. The way medicine is going has changed. And it may be by the time some of you are out practicing that there won't be, it'll be rare to see somebody like me. More of you will be employed, and that's okay. But you can still do good work if you have that same mission. Service. That's why you're here. Yes, sir.
How important do you think having osteopathic physicians is to having a more holistic approach to medicine?
One of my preceptors in my primary care clinic is an osteopathic doctor. I don't see it as a problem. I see it as a good thing. I think it's a different way of looking at medicine. Modern medicine, the Sir William Olsherstock, is new. People have been using herbs for thousands of years. People have been using touch and other things for thousands of years. So I don't see it as a problem. I just see it as another way. And I was very comfortable seeing an osteopathic doctor when I was in Ohio, and still would be now. Yes, sir.
You were talking about the concierge service kind of
Yeah.
healthcare. I was wondering how exactly do they come up with the pricing up front, and then if one of the patients goes over, how do you finagle that with the patient? Like, do you charge them more afterwards?
You're signing a contract with me, so we have, kind of like your telephone. You go over your minutes, you pay more. We have that kind of agreement. You pay a certain amount of set fee, and then for extras, I will detail that in the
So for some
contract.
services that are listed, you say this will cost extra on them.
My brother pays $5,000 a year to his doctor for his family. I think he's crazy, but that's what he does. He and his wife are healthy. The thing that their 3-year-old daughter goes the most to the doctor, and usually they don't use it all, but they're comfortable with that system. Of course, they live in a bigger city, Toronto, and are able to deal with that, which is odd because he has the background of socialized medicine, but for them, they've chosen to pay extra.
Okay, so my question is, how has Obamacare affected you in your business, and what foreseeable challenges do you see with it in the future?
I love that question. I'm not scared. Obamacare has actually provided me with more patients to see. So as a businessman, it's helpful. That's it. And most people, that's what they say. The hard part is to think, oh, the government's going to tell me where to go. My patients will tell you, most of them who have that plan or one of those plans, they're happy to be able to go to the doctor because a large percentage of them we're not able to. So the fear that we hear on TV and radio and whatnot depends on your background. There are physicians, I have colleagues who changed their practice because of Obamacare. They didn't want anything to do with it because it is true. Some of those plans pay less If you run your own business, you can change your model. That's why some of my colleagues have also gone to an employed situation rather than owning their own business, because they don't want to deal with that. That's fine. But for me, it's provided us with more volume, and we had the capacity to handle that. I'm in trouble.
Your professional relationship to hospitals, you have a life now, but you don't have to go back.
I get them every night, yes.
That's right. But that always seems strange. I go to my physician, he says, you need to go to the hospital. And all of a sudden, the physician disappeared. Now, they may be reporting to him and telling him stuff, but he doesn't deal with me anymore. The whole new system, I'm immediately dropped into another system. How do you relate to that?
I am comfortable with it now. I was not. Part of what we looked at when I was with the larger group in Cleveland, before we made the decision to leave the hospital, is how often our patients were actually going and being admitted in the hospital. Because in the early 70s, your doctor met you at the hospital. And throughout the 70s, many still did that. By the time you got in the 80s, you had your doctor going to round on you in the hospital. He may even come to admit you, but the ER doctor was managing your emergency room care. In fact, that specialty was relatively new by the time I was going to medical school. And so I think part of it had to do with the change in culture. We looked at statistics and realized that many of our patients were going and being admitted, and these were our senior patients. And I focused on those because, you know, the larger percentage of healthcare dollars were spent at a certain point in life, the last part of your life. Once, twice a year. People with chronic illnesses, multiple chronic illnesses, maybe once a year for pneumonia, once a year for some heart thing. Most of the time, they were not being admitted. They may go to the emergency room for something, but if I'm doing my best when it comes to prevention, they're okay from the hospital. The other part that was uncomfortable for me was communication. You know, if I'd done a test in the hospital, in my office, and then all of a sudden you go to the ER and get admitted, they don't know that I did a test already unless they call me. So that took a while, to where now there are some requirements by each hospital to determine their outreach to us, to see if, you know, I can send something to them. And because I now, for the last couple years, have electronic records in my office, when the ER calls me and says, hey, you had such and such test, I pull up my laptop, find that test, and I can send it to them right away. It's there within minutes. And so they don't have to repeat it, or they can use it as a baseline to compare. So it's taken a while, and I think whereas my apprehension was high back then, getting away from liability and being able to communicate in a different way with the hospital doctor,
Have a life.
get home especially, that's the best part of it. I don't wrap. Yes, ma'am. You're next. Oh, go ahead.
Back to the concierge clinic, I'm trying to wrap my head around it. So if you say it's like a flat rate for $1,000 a year, and they see you one time, is there like a rollover plan for next year? They get any of that back? And you said if they reach their quota, they're gonna pay more anyway, so what would be the point?
Usually not, but that can be arranged various ways. Well, because you've estimated what you've spent the last 2 years on your health out of your pocket. You've estimated what you've spent to deal with your family's care, and you've decided that if I set that target and we do what we can to stay healthy, I'm not likely to over. It benefits both ways. Some of the doctors actually give you extra things. You've got easy access. You've got direct phone number. One of the doctors I know will allow you to call him directly instead of going through an answering service. That type of thing. You get a special touch. It's more expensive, but you have to determine if that type of budget you have and what you're looking for in communication with your doctor, if it works.
Has the rate of reimbursement, kept track with the rate of doing business?
No, not even close.
Can you give me like a margin difference?
Anecdotal, because the data that supports that shows that we're behind. And probably the biggest example you might be aware of, you may have heard of every year Congress would have to deal with what's called a doc fix or doctor fix. Every year they'd have to decide, well, are we going to give them a Medicare increase, or are we going to have to cut back? 15 years ago, or maybe 20 years ago, plan was set in place that each year they would be decreasing the amount of Medicare dollars are spent on physicians. And so the cost of living was going up, the cost of expenses, all that going up, your overhead was higher, but they were cutting back on Medicare. It caused a lot of doctors to get out of the Medicare system and no longer take Medicare patients. Last year, Congress, or the year before last, they agreed to look at it differently. So that whole doctor fix that had to be voted on every year has changed. And so they're trying to catch up, but at this point, it still does not match the cost of doing business, which is another reason why some of my colleagues have said, I'm not going to deal with it. I'm either going to drop Medicare altogether, or I'm going to be employed by somebody and just take a salary.
Is it the same with the private insurance companies like Cigna and Blue Cross?
A lot of them follow Medicare as their standard, and they will budget, they will set their marks off that, but most of them pay higher than government insurance. Yes, Mark? Hi, Mark.
Question regarding the shortage of primary care physicians. So the trend has been over the recent past to move more towards specialization. So for the consumer, if it hasn't changed already, it's changing, it's been changing quickly. Can we get to a point where consumers start going directly to specialists?
Yes.
Is that where we're headed?
In fact, Medicare allows that now. Some private insurance will allow that now. There's some that require a referral, and you as a consumer may determine. I know one company that requires me to review all that and do the referral. Most times it's not a big deal, but there occasionally I'll say to my patient, you don't need to go see a specialist. That's something we've already looked at. And they'll either be satisfied with that if they trust me. If they don't trust me, they may do other things. But yes, there's a time, I expect, when you yourself will be able to say, I want to see a specialist because I've evaluated this way. And I mean, there's lots of information out there. That's part of freedom. Or that's what we call it. It's expensive.